Thank you for inviting us to talk about our study today. I don't know if Danielle would like to say hi before we go ahead with the presentation.
I'm just going to unmute myself. It's nice to see everyone here today. Thank you so much for inviting us to come to present on NB Hears. We're really excited to talk about it.
Thanks, Danielle. And Danielle's going to be helping me to answer some questions because I actually had to do most of this study remotely because of COVID at the time. I was not able to be in New Brunswick as much as I was really hoping to. And so Danielle and the Loch Lomond Villa staff were really the ones that were actually conducting the study. And so if you have any really practical questions about how their study was implemented, then Danielle will be happy to answer them. So I'm going to go ahead with the presentation. And as you know, the study was funded by the Healthy Seniors Pilot Project, where we assessed the acceptability and benefit of HEARS, the community-based hearing care program in the St. John area of New Brunswick. And the HEARS program was designed by a team at Johns Hopkins School of Medicine to address the public health challenge of untreated hearing loss among older adults and the gaps in care. As you probably know, hearing loss is highly prevalent among older adults, and it's associated with a number of health concerns, declines in cognitive, physical, and mental health. And recently, the focus of dementia research and care has really shifted towards prevention and interventions that might be protective. And the recent Lancet Commission report spotlighted hearing loss as the leading, potentially modifiable risk factor for dementia in both their 2017 and their 2020 publications. However, despite this, most people delay getting help for hearing loss for an average of 10 years after they know that they have it, and fewer than 20% of people who could be helped by hearing aids actually use them. Because of the socioeconomic factors contributing to barriers like lack of awareness, access, cost, and stigma, older adults with low incomes are unlikely to go to see an audiologist, and they're even less likely to get hearing aids. To meet the need for new, accessible, and affordable models of care, the Johns Hopkins team developed an evidence based hearing care program designed for delivery to older adults in the community while addressing key barriers to hearing care. And the rehab intervention consists of education and counseling about age related hearing loss and includes a choice of two low cost devices that can be purchased online or over the counter without the need for a prescription from an audiologist. And you may be aware that over the counter devices have become, they've really had a high profile in the media lately because they are now being regulated by the FDA in the United States. And this has not happened in Canada yet, but we're certainly hoping that it might come. And so these devices have been used by the Johns Hopkins team. And I just want to state that they were very rigorously tested for quality and functionality and for suitability for the use by older adults. And that's why we're using these devices in this study. I also want to just quickly say that recent studies have really emphasized the importance of good hearing rehabilitation uh, accompanying the use of devices. It's not enough to just fit hearing aids. You have to make sure that people understand how to use them and that they're going to use them effectively, because if they only use them 1 or 2 hours a week, then they may as well not use them. It's really something that you need to use consistently in order for them to have the benefits that we hope they will have on health, and certainly for the people using them to become accustomed to them and adjust to using them. And the goal of this program was to empower older adults to learn to use effective communication skills along with using the over the counter technology to improve communication. The program was first piloted with a low income minority group in Baltimore around 2015, where community health workers were trained to deliver the intervention and devices were provided at no cost. The pilot study was successful in demonstrating the efficacy of the intervention in improving communication function at 3 months post intervention. But it was a small study, and we wanted to bring it to Canada. And we did get some funding to do the program, first of all, in Toronto in 2017, where we adapted it for delivery in 4 community centers here in low income areas of Toronto, where the intervention was delivered by a communicative disorders assistant on staff at Baycrest. The over-the-counter devices were offered for purchase at minimal cost because we wanted to see if the program could be self-sustaining. We later delivered the program on a much larger scale in New Brunswick, as you know, identified in Canada's National Aging Strategy as the perfect living lab for developing solutions to the growing healthcare crisis and shifting resources from costly treatment to more affordable and proactive health interventions, since New Brunswick has the highest number of low-income seniors in Canada. And the main differences in implementation in the 2 provinces were that in New Brunswick, a licensed practical nurse or LPN delivered the intervention and the devices were provided at no charge. Thanks to the Healthy Seniors pilot project, we were able to have more funding, and it did enable us to provide the devices at no cost, which enabled us to study the impact of the use of more devices, so more effectively. Eligible participants were aged 60 years or older. They were community dwelling, English speaking with mild hearing loss or greater, not currently using hearing aids. Where possible, they had a communication partner who would participate in the study. Their hearing thresholds were measured with a tablet-based audiometer with shoebox software and insert phones. This is an online screening and assessment software that can be used on any kind of device, such as a tablet. In this case, I believe it was an iPad. Cerumen management was performed where indicated, and research staff were trained to recognize any medical red flags that might require a referral to a physician. The rehab intervention took between 1.5 to 2 hours to deliver, with a communication partner present where possible. Participants were called 1 week and 1 month post-intervention as a quality assurance measure, just to make sure that they were managing well, they didn't need any additional help or education or support, and to make sure that they were using the device effectively and that the device they chose was working well for them. And then outcome measures were collected from the participants and communication partners where available 3 months following the intervention. The HEARS intervention is really a lovely little rehab module. It consists of setting personal hearing and communication goals. On the left-hand side of the slide, you'll see various communication challenges in picture form, things like communication with a partner or conversation in a group, listening to TV, radio, phone, being able to hear things cooking in the kitchen, things like whether the kettle is boiling over, stuff like that. So they each set their hearing goals, and then they were provided with education about age-related hearing loss and behavioral communication strategies. These are the conversation tips and tricks that you see on the right-hand side. Things like getting the person's attention first, making sure you're speaking face-to-face to encourage lip reading, speaking slowly, listening for key words, things like that. And these are some actual excerpts from the materials that were developed by the Johns Hopkins team that were used in the training. Participants learned that the principles of better communication include all these things. They include understanding the basics of their hearing loss, how to use the device effectively, and using good behavioral strategies. Because the technology alone cannot fix all of the problems. For example, with age-related hearing loss, one of the big problems is that our brains process information more slowly. And so no matter how good your hearing aid, if someone is speaking quickly, as I've learned at my age, then sometimes amplification alone doesn't help. So using the strategy of asking them to speak more slowly is a necessary strategy to use. The HEARS training approach incorporates principles of instruction for older adults, emphasizing strategies that enhance self efficacy. You set a goal, such as learning to put the device on. You watch the teacher do it. You practice with help from the teacher, and then you try it on your own. And participants are given the booklets used in the training to take home. The printed materials use very simple visuals and icons and large font size that you can see here. Participants choose one of two over-the-counter devices that, as I said, were selected by the Johns Hopkins team and tested and selected based on their not only their availability, but also their cost, their sound quality, and older adult-friendly features. In New Brunswick, we used the Sidekick and the Super Ear 9000. They're both rechargeable. The Sidekick is a Bluetooth-enabled ear-level device. That's the one that you see here on the left-hand side of the pictures of the devices. And it's amazingly sophisticated, actually, a lot cheaper than the traditional hearing aids, and yet it has quite a few of the features. Being Bluetooth enabled, it can be paired with a cell phone or with any other Bluetooth device. And it can be programmed actually because of an app that's downloadable on a smartphone to the individual's listening needs. You can actually do an in situ hearing test with the device so that it will adapt the response according to your hearing needs. And that can be done either with the participant's own smartphone if they have one, but because a lot of the older adults don't, especially low income older adults, don't own one or use one effectively, then that can certainly be programmed by the one used by the person doing the fitting. The Super Ear in the bottom right hand corner is a larger body worn device that was offered as an option for those participants with limitations in things like manual dexterity, vision, and cognition. They're larger, they're more robust, they're less easy to lose, and they're a little easier to manage manually if you do have manual dexterity or vision issues. In an earlier study, in Toronto, we delivered the devices for purchase, as I mentioned earlier, at low cost. But because we were delivering in the program in very low income areas, unfortunately, most of the participants could not afford to purchase one. And although they would have liked to, only 8 out of 30 participants were able to purchase a device, indicating that the program does not appear to be financially sustainable in very low income communities, such as the areas we selected in Toronto. So, in contrast, all of the New Brunswick participants chose to use one when they were provided at no cost. And the majority, over 80%, chose the ear level Sidekick device with the Bluetooth connectivity. Training was a really important factor as these seniors would not tend to order devices online, number one. And also, they obviously need support and instruction. If a device arrives in the mail in a box, then you have to know how to operate it, put it in your ear, program it, and so on. And so, this is why it's so important, even if over the counter hearing aids do come to Canada, it's very important that that support is still there and that audiologists are still able to provide those services to support device use, even if the services are not actually attached to the dispensing of the device. 71% of those screened and 91% of those meeting eligibility criteria chose to participate in the program, and 86% of those completed it. The mean age was 75, with mild to moderate hearing loss in the worst ear, which most self-reported. Although participants were encouraged to include communication partners in the study, only 9 or 7% were actually recruited, probably because of the pandemic at the time. Over 80% had an annual household income of less than $50,000, and a quarter had an income of less than $20,000 a year. Participants were screened for cognitive impairment with a mini-cog at baseline. And this was to aid in controlling for any potential confounds, but participants weren't excluded on the basis of the results. And the mean Minicog score of 4.2 indicated that the participants had a lower likelihood of dementia in this study. All of them chose to be fitted with devices, as I said, and most of those were the sidekick. The outcome measures were selected for consistency with the ones used in earlier iterations of HEARS by the Johns Hopkins team to assess the effectiveness of the intervention across a range of domains. These were communication function, social support, loneliness, and quality of life. Measures in the blue area on the slide were administered at baseline, and the measures in the green area on the slide at 3 months post-intervention. The Client-Oriented Scale of Improvement, or COSI, is a measure widely used by audiologists at the time of fitting hearing aids to assess progress towards achieving specific communication goals that are chosen by the participant. The hearing handicap inventory for the elderly is a very commonly used measure of self-perceived hearing handicap in older adults. And questions are things like, does a hearing problem cause you to have difficulty when attending a party or a group, for example, or having a conversation with your family or watching TV? So they're simple questions that are designed for older adults. Other measures were for social isolation, loneliness, depression, and listening self-efficacy. Acceptability and feasibility of the program were measured with the International Outcome Inventory for Alternative Interventions that assesses use and effectiveness of non-hearing aid rehabilitation interventions such as assistive technology and behavioral communication strategies that are used in the HEARS program. Program evaluation surveys were administered to participants and their communication partners where available. Qualitative data were collected during the interviews at 1 and 3 months, and the program evaluation surveys. These address participant experiences, and the response themes were analyzed. The primary outcome was the change in self-perceived communication function from baseline to 3 months post-intervention, as measured with the hearing handicap inventory. And the improvement in communication function or reduction in perceived handicap was significant and similar in all iterations of HEARS. The New Brunswick results were most similar to the ones obtained in the Baltimore pilot, where all the participants were given the devices at no charge, and higher than in the Toronto study, where participants were required to purchase the devices and therefore fewer participants used them. This suggests that although the behavioral intervention on its own was beneficial in Toronto, the use of amplification devices definitely seems to contribute to the overall effectiveness of the program in reducing communication handicap related to hearing, which makes sense. The change in hearing handicap score also compares favorably to improvements seen with hearing aids in other studies. The Client-Oriented Scale of Improvement, or COSI, showed that in situations in which participants said they'd like to hear better, by the way, the most commonly identified goals were conversations, 97%, TV for 55%, and telephone for 6%. Over 80% of the participants rated improvement in the better category for their top 2 goals 3 months following the intervention. And in the International Outcome Inventory, which assesses use and benefit of the intervention, scores for all 3 items most closely related to the outcomes of interest were above the 3 out of 5 cutoff, which is the dotted black line on the diagram, on the graph, indicating a high overall use and satisfaction with the program. Most participants used their device and communication strategies regularly. They reported significant benefit, and they felt the program was worth the effort and improved their enjoyment of life. The program evaluation survey supported this finding, with benefits reported by 96% of participants and all communication partners. Most reported that the program enabled them to achieve their communication goals and gain confidence in communication, contributing to their overall sense of well-being. Other domains where outcome measures showed significant improvements after 3 months was social isolation, or inclusion, and listening self-efficacy. And these are highlighted in pink on the table. The increase in listening self-efficacy is particularly important because it's recognized as being key to the management of chronic health conditions, including hearing loss, such as successful use of amplification and learned communication strategies. As in the other HEARS studies, findings indicated no significant change in loneliness and depression, although it's hard to say how much in this case it might have been influenced by the pandemic in the New Brunswick study, which we know had a considerable influence on loneliness and depression. While COVID restrictions limited social interactions and activities, participants also reported that the program helped them use remote communication more effectively, enabling them to stay more connected socially, especially with their families, and contributing to their overall quality of life. Qualitative data fell into two major categories, reflections on the program experience and the impact of participating in the program on participants' hearing concerns. Program experience themes relate to the project's primary goals, namely feasibility and acceptability. For example, an example of an acceptability quote was, "It's helped a lot and gives people a chance to see if they need a hearing device. And for some who can't afford expensive ones, gives them a chance to have something as well." Communication partners also expressed appreciation for the knowledge that was gained and the impact on participants' self-efficacy and improved communication. A recent randomized control trial of the HEARS program that was just very recently published with 151 participants from 13 community sites in Baltimore, where a randomized group of half received the HEARS program and half were assigned to a waitlist control group, supported results of the New Brunswick study and provided more powerful evidence that the program improves self-perceived communication function among older adults with hearing loss compared with a control. And if you're interested in reading about that study, there's a reference on that slide. The successful delivery of HEARS in 3 different communities indicates that it's an effective new model of care that can be modified for adoption and implementation in different countries, provinces, and settings. The core principles are adaptable to local conditions and needs. The intervention can be delivered to a broad range of older adults by a variety of trained personnel. In the 3 different situations, the trained personnel, first of all, were community health workers, then it was a communicative disorders assistant, and then it was a licensed practical nurse. Education materials are suitable for widespread use with older adults, being largely pictographic and easily translatable into other languages. And the devices can be selected according to local availability, preferences, subsidies, and assistance programs. And obviously, those devices are going to change as technology evolves. We really hope that Toronto and the New Brunswick HEARS studies will be proof of concept projects for a larger Canada-wide program, as the Johns Hopkins team plans to do in the United States. We know, because we've heard from so many international bodies, particularly the World Health Organization, that it's so important to screen for hearing loss, especially for older adults. It really is something that we can do something about, as many of the other health risk factors, especially the dementia risk factors, can't be so easily addressed. But we can identify hearing loss with a universal hearing screening program, and HEARS has a screening component to it. And then by making amplification devices more accessible and affordable, and addressing the stigma issue, because I think we all know that there's considerable stigma still among older adults about wearing hearing aids. And we need to stop promoting hearing care as part of a healthy aging program. For example, the National Dementia Strategy is refocusing on modifiable risk factors now, and hearing care will hopefully be a part of that. We're certainly trying to incorporate that at Baycrest, and Baycrest's focus is on cognitive and mental health. And we've done some other studies here, screening for hearing loss in the Bakehurst programs, particularly memory programs. In the United States, the Johns Hopkins group co-founded in 2014 a nonprofit called Access Hears, which has been supported by the Hopkins Social Innovation Lab, which is an early stage incubator that funds innovative, socially conscious ventures. The program and the materials are expected to become available for purchase in the near future. And the link for Access Hears is shown on the slide here. So we're very optimistic and excited about the HEARS program going forward. We really believe that it really answers a need, which we're now so much more aware of how detrimental hearing loss can be to health, and this is a program that can really address that concern. Thank you very much for listening to me. Danielle, would you like to say anything now?
I can. Thank you so much, Marilyn, for doing the presentation. So I can just add a little bit to what Marilyn said as well. So I was the research coordinator who helped with NB-HEARS near the tail end of the project. So within my role, I really helped with the data collection at the 3-month mark for the people who are finishing up the intervention. And overall, I heard such positive comments from the participants overall really helped their overall quality of life. Some feel-good stories that I heard from a lot of the participants was, even being in the kitchen, they heard the birds chirping from their windows for the first time in so many years, just hearing their spouses better too. So a lot of great stories came out of NB-HEARS, and I think it was such a great format as well. A lot of people really enjoyed that we provided so much education to them on how to use the devices and the overall tips and tricks on how to hear better, but as well following up with the participants to see if they needed any help or if they had any questions about hearing. So I think this really made a difference for people. A lot of positive comments, just people really enjoying working with the research team as well. One thing I will say, just to finish up as well, this project happened during COVID. So there was a lot of stop and start with the project for being able to do data collection and providing hearing devices. And I think just looking at the research results as well, we still had such positive outcomes. And I know as well, like within my role as the director of research at Loch Lomond Villa, I oversee nursing homes without walls, and I know the government of New Brunswick's really working on, having 20 sites around the province for helping people age in their homes. So having nursing homes without walls to be able to support people. And I think that NB-HEARS could be such a great way to be introduced into nursing homes without walls, to be able to provide people with hearing education and these hearing devices as well.
Thanks, Danielle. I think that's really a wonderful idea because we know that so many older adults, particularly the institutionalized older adults, do have hearing loss, and they also have so many other comorbidities that it's difficult to know sometimes. And I believe we need to really introduce a more objective way of screening for hearing loss rather than just asking a question, because it's difficult sometimes to differentiate between hearing loss and cognitive loss because of the communication concerns being so similar. And so I think sometimes when we just ask a question, if we're doing an admission assessment or trying to determine best care, then it's not always, you don't always learn that because there's a lot of denial from my experience working with older adults. You ask if they have a hearing problem and they will likely say their hearing is fine unless it's very obvious. And that's what I've learned from screening in the community, is that truly, many older adults are not aware that they have hearing loss because it's such a gradual thing. It's an invisible handicap. Others are not aware. And so it's something that we're really missing an opportunity on addressing unless we do introduce some kind of basic hearing screening, particularly at the point where care is required.